Good morning, everyone. I want just to say that I'm honored to be able to introduce one of my mentors, James Burroughs, and I'm going to refer to him by James, if that's okay with you, Mr. Burroughs. Excellent. Okay, so James Burroughs II is Senior Vice President, Government and Community Relations, Chief Equity and Inclusion Officer for Children's Minnesota. James joined Children's Minnesota as the first Chief Equity and Inclusion Officer in January of 2019, and he is now the Senior Vice President, Government and Community Relations, Chief Equity and Inclusion Officer. He is responsible for advancing equity and inclusion across the organization, as well as leading advocacy, government affairs, and community relations. Quite a big job. Mr. Burroughs' key focus areas include patient quality initiatives, employee recruitment and retention strategies, organizational culture, and increasing financial investment with diverse businesses and initiatives that address the social determinants of health for patients and families. He also, I don't know how he has time, leads Children's Minnesota efforts to foster community relations and accelerate engagement in government affairs to advocate for policies that positively impact the health and well-being of children. Mr. Burroughs has more than 25 years of experience in the areas of nonprofit management, equity, diversity, inclusion, as well as employment law. Prior to Children's Minnesota, Mr. Burroughs served in the office of Governor Mark Dayton, where he was the state of Minnesota's first Chief Inclusion Officer. Mr. Burroughs has a Juris Doctorate from Georgetown University Law Center in Washington, D.C., and because he was smart and listened to his mom, he obtained his Bachelor of Arts at Morehouse College in Atlanta, Georgia. He is also, probably most importantly, the proud father of Teresa Ann Burroughs. And I just want to say, James is in high demand because of his wealth of experience. And so I just really appreciate that he took up my invitation to come and speak today. Thank you, James.
Thank you for the wonderful introduction. And I'm going to shorten it next time because I was like, who is this person talking about? But I want to thank you for that. And thank everyone here for allowing me to speak to you this morning. I really appreciate that. You can have anybody here speaking to you, but I appreciate the invitation as well. Anjali called me her mentor. I'm her friend that gives her answers and helps her think through things. And she's my friend too. So we mentor each other as well. I also want to thank, before I get started, my co-parent. Today, Teresa Ann Burroughs, my daughter, she has sickle cell disease, but she's last 3 days have been kind of painful for her with her disease, and she's been home from school. So by co-parenting, my ex-wife is taking care of Teresa while I'm able to be here with you. So I want to thank her for that, and thank my daughter for hanging in there and being a trooper that she is as a sickle cell warrior is what I call her. So I want to give a shout out to her as we begin today. There are no financial disclosures or any other disclosures that I have for this presentation, so I want to get that out of the way. I also will say this, you will leave this presentation with a few answers of maybe some of your questions, but you'll leave with more questions than answers, and that's the intent of my presentation too, to get you thinking about different things around equity, inclusion, and diversity, and not give you all the answers to them, because those answers you'll be able to find on your own in doing this work. Also too, there will be questions at the end of the program. I encourage you to populate those in the chat, and Anjali and others will help me guide through those as we end the program as well. And then the last thing I'll say is I am in high demand for speaking, but I always speak to places and spaces I know that can make a difference in the lives of our kids and what we do as far as we serving them in healthcare and making it a more equitable place to do that. And I'm glad that I was invited here today and would love to come back and partner in many different ways, whether it be a grand round or any other partnerships that we could think of as well. I want to start with our learning objectives. Today we're going to learn about some definitions on equity, inclusion, and diversity and health equity. These are not the only definitions. Others will have different types of definitions. These are ones that we use here at Children's and I've used for years as well. I'm going to talk a little bit about some of the strategies we are implementing here at Children's around equity and inclusion. Once again, they're not perfect. They're not the only ones that one can use, but they are ones that we've adopted here. And then last, I want to talk about the measures of success. I'm also going to talk about racism a little bit as well. Because when we talk about equity, sometimes if we forget to talk about the things that have happened and the impact that racism has had on our communities, our healthcare system, our hospital system, a lot of times we fall short of giving equitable care. So at the end of the presentation, I'm going to give you some things around impacting racism and how that has impacted our healthcare delivery, and also to encourage you to do more and dig deeper in that as well. The title of my presentation is about the missing domain of equity as far as domains of quality. All of you know the domains of quality, so I will not bore you with repeating those for you, but you see them here. And equitable care is one of those domains. And the reason I say that it's missing, obviously it's not missing from our discussion and how we discuss equitable care, but I don't believe that we've dug deep enough to find out, what are the things that we need to do as far as equitable care and address them. We've looked at safety. We're still doing that, avoiding patient harm. We talk a lot about effective care, about providing the services for benefiting patients and services likely to benefit them. We've talked a lot about in our profession patient-centered care and focus on the patient. Timeliness, efficiency, those things are so important to avoid waste and ensure care is delivered in a timely fashion. When we talk about equity, I don't think we've done deep enough. So when we talk about equity, the definition says providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. And the reason I say we haven't dug deep enough, and we're going to dig deeper a little bit today as we go through our agenda, is if you just take a look at it, providing care that does not vary in quality. Well, if you look at equity, equity tends to sometimes make up for a variance in quality that has been happening throughout the years. So let me give you a very stark example. Let's say that there were hospitals in the 50s and 60s, which there were, that didn't admit African American patients. So for years and years up to that point, they weren't admitting African American patients. So the care wasn't equitable, wasn't equal, it wasn't any care at all. So when you fast forward to when, let's say, the admission started to happen, let's take the year 1968, just taking an example of that. Well, all the years before that provided unequitable care. In order to provide equitable care, if you provide care that doesn't vary in quality, it implies that you're providing equal or care that is equal to all patients and families. If you started equal when you didn't start at equal before, you can't get to equity because you're starting at equal. Really, what it makes sense to do is think about it this way. The only time you can think of equal care is if everyone start off in the same place, same space, same time period, same quality of care. I wanted you to think about as we go through this presentation, that hasn't been the case in healthcare. It hasn't been the case in a lot of different areas, economic development, housing, employment, but also especially in healthcare, because if you don't start there, you have to vary the kind of care you give. And eventually you want that same quality to be with all our patients and families, but it may change a little bit. The other thing I posit to you as well, it has in this definition gender, but gender identity I think is missing, and maybe some other demographics that we want to look at as far as equity are out there. So although it's physically on the domains of quality, I really want you to think about how we dug deep enough is looking at equitable care and not making sure that it doesn't just think about it being equal. I read a definition, I'm going to try to pull it up real quick on my other device. And it said about, let's see if I can find it here. Equity ensures everyone has an equal chance of getting the best possible care. Once again, using the term equal, not equity, is about not giving an equal chance, but an equitable chance as well. Our agenda real quick, talk about a little bit, we're going to talk about some language children's. We're going to talk about a model we use around our continuous improvement that factors in the domains of quality. We're going to talk about some of the leaders here, impacts of racism, and achieving achievements and engagements that we've had here at Children's. I by no means are saying that Children's, just so you get to start out, is as perfect in this area. We haven't been. I've only been with Children's 4 years. We're on our equity journey like everyone else, but I do think there's some things we're doing that we can share and highlight. And as Angela and I do over coffee and sometimes over Zoom, we talk about those things we can share. So by no means is Children a perfect story, but it's a story that's a work in progress, and we're getting towards that equitable goal, as Dr. King talks about, not having inequality and injustice in healthcare, because that is the most shocking and inhumane. One of the things in working in pediatrics helps you realize is that if we don't get this right, the kids that we have come into our doors, kids like my daughter Teresa, who's 10 years old or younger than that, we're providing them a disservice by not addressing the inhumane inequality of healthcare. We're providing them a disservice if we don't address the health disparities as it relates to, let's say, examples like well control, asthma, or combo vaccines. We're doing them a disservice as kids if we don't make sure that when things like a pandemic of COVID-19 happen, we don't adequately address some of the things that we saw went wrong because of the inadequacy of care in certain neighborhoods and communities and certain racial groups as well. Those are the things that drive my passion around this. And when I look at Dr. King's quote, who's also a Morehouse graduate of my alma mater, I want to say that we have to get this right for our kids in order for them to have a fair chance to have not only equitable care, but just care in general as it relates to the social determinants of health. They need to have food, don't need to have food deserts in their neighborhood. They don't need to have housing shortages in their neighborhood. So we have an important relationship to make sure we get this right, and I'm glad we're partnering to do that. Real quick, this is our executive leadership team here at Children's. I'm one of 9 people who report into our CEO, Dr. Mark Gorlick. I show you this picture for a couple reasons. Most of the people here, except for Jennifer Olsen and Dr. Emily Chapman, are fairly new to Children's within the last probably 3 to 5 years, 3 to 4 years, to be quite honest. And one of the things I wanted to encourage you is as you lead this work and as you do the work as you go to the University of Minnesota, I encourage you to keep in mind, you always want to make sure that you're bringing forth or hiring or recruiting from or partnering with a diverse team. And that team not only means racial diversity, but also means gender identity diversity, it means LGBTQ status, it means people with disabilities as well, because important in that is the knowledge and discussions we have around equity and inclusion are only as good as the diversity we have around the table. And that's what we want to make sure we do in our ELT team, which we call ourselves. We make sure that we do that. We have those tough discussions, and we call it rumbling sometimes in order to get to solutions that work well. And that's important for us. My equity inclusion team, I wanted to show you them real quick. Great people here. They make sure that all the work we do is excellent. I get some credit for it. I get too much credit sometimes, but they're the ones that execute the work. We added this year a clinical director of equity and inclusion. Her name is Miriam Roby. And I'm excited to have Miriam on board because as a nurse and as a hospitalist, she is in there with our patients and families on a regular basis. And she brings us a lens that we didn't have before as a team because we didn't have any medical professionals on our team. So she's able to get in there, develop solutions with our teams, and we've had a new way of looking at equity and inclusion for the patient-facing clients that we have in our departments. We also, too, are gracious enough to have partners in this work. Our Collective for Community Health is looking at our social determinants of health and other community partnerships. Our talent acquisition team helps us to recruit physicians, nurses, non-clinical positions. And all of our departments here work together in our employee resource groups where our employees help us address some of these things on a regular basis as well. So I encourage you through those partnerships are the ways in which we get things done. Here's an org chart of all the great people who work for me and with me. I'm excited because those are the ways we are able to knock out these things around equity and inclusion. I do want to just show you, this is our mission statement for our department. I won't go through all of it, but we spend a lot of time identifying what are we talking about to begin with. So we talk about inclusion, diversity, equity, access, and solutions. As you see for each of them, we have a definition around it. The worst thing you can do in this work is try to search for a goal and hit a goal that you have not defined clearly. You have not defined what diversity means. Some people mean diversity by only looking at race. We don't mean that. We want to make sure that it's differences in any way that you look at as far as diversity. Now, can you focus your equitable solutions, one on race, one on LGBTQ, one on people with disabilities? Absolutely, because that's the equity of doing that analysis. But you can't just have a definition that's not clear. So we make sure that we have those clear definitions, and when we're driving towards solutions, we're clear on what those solutions are. Create an equitable, inclusive environment and sustaining those solutions long term. So once again, if we go back to the domains of quality, if that's going to be a domain that we're going to seriously take into consideration for our healthcare services, we have to define solutions that are equitable along the way. If you look at the graphic to the left on equity inclusion, the way we do that at Children's is we do a lot of self and team assessments. One of them is called the intercultural developmental inventory, by which we look at our own individual biases, our cultural lens, and work on that through our individual development plan. We also look at our leader competencies, and equity being one of those, where we make sure that our leaders have equity coaches and advisors around having that equity lens and solving problems. Our performance metrics, we're a company that takes that seriously, and as you look at our compensation structure is built upon having a goal. You'll see right now strategic plan, having 2 of our 6 pillars that we're focusing on for our strategic plan focus on equity and inclusion, and we're rewarded for hitting those, and we're not rewarded for not getting them. So we make sure that's a part of our performance measures as well. It ties to our values and also the learning development side. We do have an amazing simulation bias course taught by Dr. Marie Burroughs, and that's something that's working with our clinicians as well. We're doing more around equity coaching with our leaders, and we're going to do more training and development as well. I will say this, equity and inclusion and diversity is not just about coaching, it's about making sure, it's not about training, it's about making sure you have a different lens and asking the right questions as you go through this work as well. But those are some of the ways in which we supplement this as well. Real quick, our vision statement, I won't go too much into it, but it aligns with our equity inclusion. Every family is a essential part of raising healthier children is our children's vision statement. And we want to make sure that happens by making sure our parents, our families, our community feels valued and respected. And we're reducing those health disparities that we talk a lot about, where we have more solutions to have equitable care. I strongly suggest, and you've probably done this in your plan already, what are your success factors and what do those things look like? Those are important to address because people need to see and practice what are the things that we're doing. We want to make sure we are eliminating structural racism and health disparities. We define that in this presentation, and we want to make sure that our solutions are geared towards that. We want a workforce that reflects the diversity of our population we serve. We serve about 40% persons of color in our inpatient and outpatient services. We want to make sure that our number right now at 24% people of color increases to reflect those patients that we serve. We also want to make sure that we're investing in businesses in our community to make sure those businesses are thriving. One of the things you may not know is as businesses and communities of color grow and get bigger and thrive, those communities, in fact, hire more people of color from the neighborhood, invest in those communities, and help those social determinants of health that we don't directly affect, and can indirectly affect by investing in those businesses as well. We also too provide the equity lens. Like I said before, asking more questions around equity and having answers the important piece, but making sure that you have the right people at the table. The table is not built before you invite people to the table, and also ensure that you're doing the best in class work in collaboration and partnership as well. This statement here, I'm not going to read it to you, but when George Floyd was murdered, a lot of CEOs, including my own, thought about and wrote statements around what happened in the community. This statement was written by Dr. Burroughs, and I want to just highlight 2 things here. As business leaders, it talks about being committed to greater equity, diversity, and inclusion. And as business leaders, it talks about at the end that we're committed to investing in substantial change in our organizations to address racial equity and social justice. This statement was made in 2020 in June. It was adopted by my CEO and other 50 CEOs that signed on to it. We have a lot of work to do, but I wanted to remind you and others that as we do this work, we need to not only reflect on George Floyd, Philando Castile, who was killed by police in Minnesota, Jamar Clark was killed by police in Minnesota, and all those things, we also need to reflect upon what do we want to be as a state, what do we want to be as a profession of pediatricians and doctors and nurses and what do we want to say our legacy is going to be. And we got to make sure we continue to do this work, not just when things happen, but also to keep it at the forefront of what we're doing. Here's a resource I'm going to suggest that you take a look at. The CEO Action is a group that a lot of companies have joined, but most importantly, there's a CEO pledge there, but more importantly, there's a library of lots of resources from around the country that people can take a look at, and that's important to do because it helps with the work that we're doing along the way. I love cute kids. I love cute employees and everything like that. So when I put slides in here, I always like to acknowledge the great people who work here and also the families and kids that we serve too. Real quick on this one, this is our framework for continuous improvement. I don't want you to focus too much about the continuous improvement work. That's something that we're working on, but I want you to focus on the little house here. And it's amazing because I believe Dr. Tamika Lashige, no longer working with children, but she was a values and clinic expert here at Children's while she was here. And she talked about how the domains of quality build a house that services our patients and families at the center of it, and it also provides that high quality, equitable care. So you can see here, safe, effective, timely, and efficient domains of quality help build upon our covered by patient family centered and high equitable care. Our continuous improvement strategy is about asking the right questions, solving root cause problems, identifying experiments and hypotheses to test those experiments, and in a way that makes sure that it's getting better overall. We want to do that same thing around equity. We want to do that same thing of making sure that we are looking at ways in which we can get better, become more equitable, and reduce waste, add value, operating stability, and how the standard processes or what we call, leader competencies as well, and respect for people. The reason I put this here is diversity, equity, inclusion can't be a separate thing to do. It should be built upon your framework of how you're getting your work done, and how you're going to continue to get that work done as well. So that's one of the things that we focus on here at Children's too. Structural institutional racism, I'm going to strongly suggest you find the definitions that work for you, but also to talk about them as they relate to the processes and things that you do in your work. And this is not just at the University of Minnesota, this is anybody listening to this. When you talk about ending disparities or ending racial inequity, you have to start with understanding what are these L's of structural institutional racism. Think of them more as political, cultural, social, economic frameworks that disadvantage people and have them for a while. They can be in banking, they can be in employment, they can be in healthcare, they can be in law, but they produce those inequities and outcomes that have those disparities. And they're typically unfair and unjust practices. Most of them weren't intentionally put together that way, but they were put together in a way that they weren't looking at the disparities they would cause. And people who were running those particular systems didn't care too much about addressing those inequalities. Now we're in a different place. More people are focusing on that. So I'd say as you develop policies, as you look at your own policies that you currently have, making sure they don't have that unintended impact of racial disparity. The other thing I'll say is when we talk about equity, what do you mean? This graphic here, I like to use it. Some people have a problem with it. Some people use a different graphic, but I want to explain it so it makes sense to y'all. Social justice to me and equity eventually will have no barriers to people having access to high quality healthcare, high quality employment, housing, etc. That far right social justice picture is that fence you see on the other slides is not in the way. The kids are watching a baseball game, is the analogy we're using here. Those kids are allowed to see it, and there's no barriers in the way. That's what we want to get to. Equity helps address some of those barriers that currently exist by giving each group something different by which to succeed. So you see here, there's the different heights of the children. The one shortest guy has 2 boxes. The one under him or her or they has 1 box, and also the tall kid has no boxes. We're not giving everybody equality. We're not giving everybody the same thing. Go back to our definition of equitable care. We're not saying we're not going to vary equality or have things that be equal. We're saying we're going to give each group what they need to be successful. So that's giving a group something different because their needs are different. That's what we're going to do. We're going to eventually get to a point where all of it's quality healthcare. We'll make sure that we're not talking the same. You saw that the picture to the left of that is equality. Everybody gets the same. Not everybody can see through the fence with that. And the reality I want you to think about, our society, in the United States and also the world has had a basically a fight with racism for a long time. A fight meaning that it has impacted systems, people, cultures, outcomes for a long time. That reality means that a lot of people have a lot of boxes based upon the disparate treatment of others who are in that sunken hole. Doesn't mean we have to stay that way. We're not going to stay that way. But we got to be honest, and when we talk about equity and inclusion, that we're not talking about everybody starting the race at the same place. We're talking about some people started at a different place because of systems, not necessarily individual people, but systems that led to that. So we got to change those systems in order to change that reality as well. Racial equity, we want to make sure that there's no more outcomes determined by race. That would mean in health, in wellness, wealth, education. Right now, we have some of the largest racial disparities in Minnesota and have been for like at least the last 10 to 15 years. We got to do better. We got to do better by addressing that need. We also want to impact those structures by looking at how we restructure decisions and planning going forward. And the best way I can describe this is somebody's in my head right now is Dr. Josie Johnson, who just received an award from the University of Minnesota for being an amazing regent when she was a regent. I think she was the first Black regent ever when she was appointed many years ago. And she received an award yesterday, and her being on the regent board and others coming after her, people of color and others being in places and spaces where they can shape decisions, or policy boards at the hospital, or policy boards in education, are making sure that we are having those folks who are negatively impacted by racism at the table creating solutions. One of the things that people always talk about is being invited to the table. I would encourage you to use some other language in saying this. Help them help you build the table, build the structure, and work together in order to have those equity. A lot of times we forget and create these solutions, and we've done it at Children's, and we're getting better at hopefully not doing it in the future. We create a solution that says, hey, here, community, make this work for you, rather than saying, hey, we don't know what's going on. We want you to come to the table and build with us. That's what we talk about racial inequity is in addressing that. Health equity is similar. It's a fair and opportunity to be healthier, moves obstacles from discrimination, also removes those barriers as far as the social determinants we talk about. Quality of education, housing, safe environments as well. If 80% of the things are controlled outside of the walls of healthcare system, and we only control 20% of that, what happens to our kids that we serve, the thing we have to do is how do we help address that 80%? How do we make sure that our voices are heard as well? One of the ways in which we do that is looking at different ways to address that through things like healthcare and hair care. One of the things at Children's we wanted to focus on is how are we getting in our own ways sometimes? And sometimes we have policies or we have things that we are doing that may not be addressing the full person that's coming into our door. So one of the things we didn't have a lot of for a long period of time was addressing the needs of African American or Black young patients that came in who needed their hair done or in a way that they've been here for a long time. We were going to serve them like all the patients, helping them do their hair, making sure that if they're doing surgery or something like that, that the hair is properly taken care of. But we didn't have the products. We didn't have the people who knew how to do Black or cultural hair. One of the things we said we're going to do differently is through our health equity department and our nurses who actually reached out and said, to our health equity department nurse, Adrienne Thornton, who's leading that work, we need your help. We want to partner in this. So now we're ordering products from actually Black-owned businesses who are providing the products. We're doing the hair and helping the kids do the hair that we didn't know how to do before. And we're supporting things in government and policy like the Crown Act, which doesn't allow folks to be discriminated against based upon their hair or how they present themselves. And that's something our CEO, Dr. Martin Willard, you see the picture, supported along with the Minnesota Business Coalition for Racial Equity. Testified on behalf of that, and that was passed by the state legislature and also signed by the governor. Those are important ways in which you can lean into equity and inclusion and making sure that people understand that it's important to have partners around this work and not just do it on your own. The other thing we also leaned into and continue to is gender affirming care. Dr. Angela Gefford is our amazing chief education officer here at Children's and does a lot of great work as far as testifying on behalf of gender affirming care and also too preventing things like conversion therapy as well. The governor recently signed an executive order eliminating that, but we need to get to legislation that gets passed eliminating things like that as well. But those are voices that need to be heard, and we're making sure that equity includes a broad range of people by which to do that as well. This work starts with you as leaders, and you have an amazing strategic plan that I had taken a chance to take a look at as well. I want to highlight for those that are listening, if your equity, inclusion, or diversity goals or belonging goals, whatever you want to call it, is not in your strategic plan, you don't have equity, inclusion, diversity, or belonging goals, because that is the framework for which you do all of your work. It should be included in there and not in a separate place and space. As you can see here in our strategic plan, just we'll highlight at the bottom of pillar one, which our lead influence pillar. Advancing diversity and equitable inclusive organization is part of our frame. How we measure by the board that our board, children, our governance board, our foundation board, and it's also too how we measure ourselves as far as the quality of work. We also have created a formal structure about thought leadership. That thought leadership is not only about social determinants of health, it's not only about equity and inclusion, it's about how we show up in the community, how we show up in partnership with business. And that thought leadership leads us to a lot of discussions, not only locally, but nationally around the work that we do as well. And as you know, we established a mental health expansion this year as well. And it's not only looking at a mental health expansion by a number of beds, but we want to be culturally relevant, cultural humility, and providing those services as well. So it's a part of our plans, a part of our fabric of who we are. We also measure it. I won't spend much time here, but you can see number one, performance indicator, and number four about the health equity index are things related to and grounded in equity and inclusion. So we measure those over the years. We have a goal this year, a target, and a 3-year target as well. I also say this about goals. Sometimes people say we got to make them, achievable. Got to make it achievable, but realize too that equity has impacted us in such a negative way. They have to be goals that are very, very far stretching and very far reaching to make sure that we are giving ourselves not only enough time to do it, but also too that we're pushing harder than we need to. One of our workforce diversity goals is by next year to get to 34% of our workforce being people of color. We started at 19% 3 years ago. We're at 25% now. We're heading in the right direction. It was a very aggressive goal. It's a goal built upon changing the structure to say we're going to recruit in more different places and spaces, and we're going to do a better job of retaining people that we bring on by having an inclusive environment. We have to do that in order to get that goal. Is it a far-reaching goal? Absolutely. Is it a hard goal to reach? Absolutely. But we're committed to doing it, and we have to be committed to those goals that are far-reaching as well. We also have goals around leadership targets as far as representation. You saw our ELT team, and also too reducing our turnover rate for our employees of color, and also increasing our supplier diversity spend. The people at the bottom of this page are folks that are helping execute that and doing a great job in that work. And once again, I want to say this: it's cross-departmental, it's cross-specialty area, and it's cross-profession. What we're doing here at Children's, we're trying to do more collectively too, by working with our nurses and our docs together around equitable solutions for our patients and families, and not in silos. One of the things that gets in the way of this work sometimes is identifying the work to get done, but you silo it by a particular group, or they have their own solutions. We want to make sure, as you can see down the bottom here, our strategies are very broad, our tactics are here as well, but our key leaders transcend HR, they transcend inclusion, supply chain, collective, marketing, and communications department, and other areas as well. Investing. I turned this into a graph slide, but I want to make sure you understand it. So our FTEs around the Collective for Community Health, which is the work we're doing with social determinants of health in the community, for 2023, we're at 14.5 FTEs, while in 2021, we're at 9.5. And also, too, you see the blue line here, the budget has increased as well. Also, on the equity inclusion side, started in 2021 at 5.4, and actually was less than that prior to 2021. And now we're at 6.2. Our budget has increased. What I say to you is this: what you do in your priorities are not only determined by what you put in a plan, It's determined by what's in your budget and how you spend your money and invest your money. We can't tell community, or we can't tell others who want to say we believe in equity, inclusion, and diversity. But when you look at our budget, we're spending quite a bit less on that, or don't have resources. And we can't identify only one person in the organization who's responsible for the work. And then we say, well, where's the team to execute it? We don't have a team. We have volunteers as opposed to that one person. It doesn't mean that volunteers aren't necessary. It doesn't mean that supporters aren't necessary. It doesn't mean that in-kind contributions aren't necessary, but you have to invest in the work. We don't create our finance departments at our organizations to say, hey, we want a volunteer CFO, want some volunteer accountants. We want people that can do the work, and we invest in paying them. Same with marketing, same with HR, same with our support operations, same with our clinic operations. We don't rely upon volunteer doctors necessarily or volunteer nurses. We pay people to invest in it. We have to do that same amount of investment with the work that we do around equity and inclusion. What are your priorities? I'd suggest to you that look at faculty leadership. Those things we're looking at already, the diversity there, defining the things we talk about racism and defining what inclusion, diversity is, and also how it impacts patients and families, and then having metrics. And those are the things that I looked at your plan that you had started working on, but I wanted to make sure that you keep that energy along the way. A few more things to talk about that I want to open up to questions. I want to highlight my executive assistant, Jen Blashkow. Is an amazing assistant, and she's done a great job of keeping me in order to even get to presentations like this and making sure technology works. But even more than that, she's an example of how equity is influencing people in a way that they're doing things on their own and they don't have to be guided to. So Jen knows that we are about supplier diversity. Jen knows that we want to partner with the organization. And when she's putting together ideas as far as, where we're going to grab lunch or coffee for meetings or events or give gifts for the organization, the extra time she takes to build relationships and says, okay, where do I go look for businesses of color by which I can identify that? So she's done on her own work, looking at minority chambers of commerce, looking at businesses of color indexes to find out where those businesses are in Minnesota and making an effort to invest in those businesses by the things that we're doing that we're in control around that. She also got us in good trouble around Juneteenth. We had a scheduling opportunity that we were actually having one of our meetings scheduled on Juneteenth. She brought up to a area that, hey, we're going to look at that, not schedule something on Juneteenth, which at the time was a federal holiday, and now it's a state holiday as well. And we moved that scheduling around. No fault of anybody as far as putting it there, but she identified on her own, how can I do this and how can I solve to the root of the problem to address this concern using that equity lens. Those are the things that are so important. And then she's actually put together a whole list. I want to share this with you later of businesses that are, women and or people of color owned and or LGBTQ owned that we go to on a regular basis, by which if we're doing meetings or events, we're basically investing in those businesses. Fearless Commerce is one I'll highlight as well. It's a conglomerate of, I want to say over 250, if not more, Black women-owned businesses that are doing work in the community and would love to have partnerships and investment as well. They have a magazine that comes out that identify those businesses. So it's very important to keep those relationships. I'm not going to go into a lot of detail about how you define racism, but I want to encourage you to, as you address equity in your organization, as you talk about not varying quality because of personal characteristics, you have to address racism. You have to address anti-racism. You have to address ways in which bias leads to racism, because if you don't, what you're going to do is you're going to miss out on an opportunity to address some of the ills that have been caused by that, some of the chronic stress that has been caused to our kids and families because of racism. There's several studies that show that chronic stress in children gets in the way of their hormones, gets in the way of inflammation in their body, has physical characteristics. We know that stress can cause pain in a mother's pregnancy, and we know ways in which, despite that, there are low birth rates and other things are impacted by that as well, high stress levels. If we don't address it by looking at equity, we're going to make sure that we keep these things going, and we don't want to do that. We also need to look at it as a core social determinant of health. It is something that impacts all the other determinants we talk about. You can't talk about housing without talking about housing discrimination. You can't talk about employment without talking about employment discrimination. You can't talk about, food insecurity without identifying that in some communities that are basically people of color, majority communities, you don't have a grocery store. You don't have a pharmacy. You have food deserts and healthcare deserts as far as drugs and pharmacy. So those things have to be addressed as well in order to address that equitable care that we talk about. Racism is a socially transmitted disease. It's passed down from generation to generation to generation. Those are the kind of things that are people need to understand that it's not an isolated incident or isolated person. People have passed this down as a generational, I'll call it what it is, a generational curse, and influence others in being negative towards another group because of their race, and it's impacting that system for a long period of time. So we got to address that as how do we break that bond, break that system, and break that transmission. Negative self-esteem. What we hear a lot about now is mental health concerns around racism. Imagine if you've been treated, talked about, neglected, and treated negatively for a variety of your life, and it's because of your race or ethnicity. That has an impact on who you are, who you think you are, what you think you can do. One of the things we focus on at Children's is hiring more people who look like our patients and families in positions that our young people can see, yeah, I can be that one day. I can do that. So that negative self-esteem doesn't get in the way. Lastly, it's been also to a rejection of our healthcare system. Our healthcare system has been rejected because of the biases and racism that's in our system. There's a whole nother presentation I can do on that and make sure that you understand we were built on the foundation of racism in this profession. We can get beyond that and we can make sure we're going to do better in the future, but we have to acknowledge the racism that took place in this healthcare system and still does as we address the future. And the last thing I'll say about this is racism is going to become a public health issue in 147 cities, 41 states. The question now is, what are we going to do about it? What are we going to do to make sure that it's going to be different going forward in the future? And what are we going to do to try some of those experiments? What are we going to do to test our hypothesis? What are we going to do to say, you know what, that experiment didn't work, we're going to try something different? What are we going to do to partner across lines of, Children's Gillette, Children's Masonic, excuse me, health partners, pediatrics, to make sure that we're solving for the same issue. Healthcare for children is given in an equitable way, so we don't have that missing domain anymore. And lastly, we do a lot of stuff in a lot of different places and spaces. I encourage you to do this work because it leads to partnerships around with the Red Cross. It leads to partnerships with our EAGs here on the left-hand side. These are the partnerships where we're talking about health equity and practice with our, UHG, Blue Cross Blue Shield, other insurance providers as well. These things here are not a showcase of what we are bragging or boasting about. It's just saying people are hungry for this work. We want to make sure that we have that opportunity to give them all that they need. That's all I have. I hope you learned something from it. I hope you have questions along the way. And if you have some today, I'll take those. And if not, also too, I'm available, going forward, and Angela knows how to reach me. So, Angela, I'll turn it back over to you.
Thank you so much, James. We will take questions now.
You could probably stop your screen unless you're leaving the word document up on purpose, James, which is good to have maybe as a centering framework.
But we'll ask questions in the meantime.
One of the things, I guess I can tell I've been working in administration for a while because I was really struck by your org chart and just how many people are doing this work. And and it sounds like your team has grown, substantially over the past several years. So I just would love to hear you reflect a little bit more about the process of building your team and how you sort of thought about, we need people in this area, or, if I'm going to launch this project, this is how I build my team.
I've thought about it a couple ways. So one is when we started, it was just myself in this role. There we go. Jen had to come in again and say that she should have stopped. What I thought about this is a couple things. I was hired as a senior director for equity inclusion 4 years ago. I had two other people, diversity inclusion consultants, and I knew that as a hospital system of 5,500 employees, we couldn't address all of those needs by just that staff. So I wanted to do an analysis. It took like about a year and say, okay, what do we need and what do we miss? If we want to do supply diversity, we need some expertise in that area with the business supply chain, expertise. If we want to do something with clinicians and doctors, I love doctors to death. I'm not one, but I love them to death, and nurses, but I wasn't one. So I don't know how to provide that service in an ethical way because I don't know that. I wasn't trained in that. I knew we had to bring that position on board as well. And then also, too, we had to get an understanding with our executive team that we're not trying to train and be a diversity force. It said, you're forcing bias, and those 2 hours are going to solve your biases for the last 55 years and make you great going forward. We had to say, how are we going to give coaching advice to that? So I had to hire people who could be coaches around this, asking the right questions and building that as well. And also, I'll be honest with you, I have a great CEO and leadership team who realize we have to invest in. When I tell people what my budget is, I'm not telling you today, but I tell other people like Angelina, she's like, what? Your budget is much money for this, but you have to show that commitment by investing in that for the future.
Specifically around the budget, there is a question. First of all, comment, excellent work and presentation. And the question is, where does the financing come from? And what argument was made to spend that money on equity?
Good question. So the two places it comes from, and I'm going to get this right, was Jenny Soderholm with our foundation, which Jenny runs, raises some of that money for our social determinants of health. So we raise that through our foundation and giving it back. The other money is in the budget that comes from our generation of revenue. So every hospital system generates revenue by the services we provide. We get reimbursed by that. We make sure that some of that is in the actual budget for going forward. So I'm not a revenue generating resource. I'm not something that's going to produce a revenue. We can't bill for my services and charge that. But what we can do is making sure that if we provide equitable care, our patients keep coming. If we provide equitable care, our patients don't leave us to go somewhere else. For equitable care, we don't have the subject of lawsuits and other things around, ill treatment of care based upon race or ethnicity or gender identity. So that's where it comes from as well. It's in the budget itself, actual budget for all of our operations, and we do raise some of that money through our foundation as well around social determinants of health.
I don't see any other questions come through. James, I have many questions. And I guess it is, I was taking notes and it was interesting to me. I think you said maybe 5 times, and I think that was intentional, about asking the right questions, right? And you talked about that table, like inviting people in to help create that table. What do you do when burnout is high amongst your providers and there's frankly, there's pushback, right? Because of the burnout and, all the expectations that our providers have upon them. So how have you addressed that at Children's?
My job is to make it easy for providers. So I'm not doing my job if I don't. So my job is not to tell providers, you're doing this wrong and you're in that negative environment. My job is to say, man, okay, how can we better serve our patients that we may have some unanswered questions about? And I'll give you an example. Let's say that we have a family who's, among families, I'm an example, and they may have not a cultural understanding of the services we're providing and the why behind it. And we have a team of folks that I have to provide to our providers to say, hey, our community connect folks or our folks in our equity inclusion department to help you problem solve this and making sure that our families are better informed around them so you can provide greater care, more efficient, effective, timely care, safe care, all those social, all those, domains of quality, I then help the provider. I'm not saying to the provider, you go do something on your own. I'm saying I'm a tool for you to utilize. The other thing is this as well. When we do these grand rounds, we also, after that, sometimes work closely with our divisions of quality. So, okay, what can we do to make the patient experience even better for you? How can we use one of our what we call safety and learning reports around respect and dignity to make sure that everybody feels that they're valued and included when they come into the system. When we do it that way, our providers basically say, it's more work. Let me not be honest, it's more work. But I'm coming in as a teammate to work together on that, as opposed to, aha, you did this wrong, I'm here to punish you. So I think that's what we've said to some of our providers and our clinician staff as well. That's something we got to do even better in the future. But I think for me, it's more about that partnership and relationship has been helpful.
I always love my open mic time that I get because I'm a panelist. You shared some really nice examples of wins or things that you're proud of throughout your talk, but I just would love to hear something you're really proud of that your team has done in the past 6 months or year.
Question. So I'm proud of a lot, so I'm trying to narrow it down. I'm proud of the fact we've leaned into a particular organization in partnership in a good way. It's called the Minnesota Business Coalition for Racial Equity. We were one of the founding companies around that, and it came about after George Floyd's killing. 50 companies got together, 50, 60, and so we're going to do something different around that statement that I talked about Dr. Burroughs before. And now we're actually leaning in with a focus on Black Minnesotans, and we're leaning in to help them push investment in the Black community, help push investment in Black-owned banks, help increase Black employee retention and development. We're listening about Black employee and professional development through that organization. Tiffany Daniels, who's their executive director, we're working closely with her on that team. And I'm proud of it because it's a model that can be used not only for Black employees, Black Minnesotans. In the future, we could use that for the Latino community, the Asian community, other communities as well. And it's been supported not only by the business community, but our government folks as well supported that. The NBC area have a policy division, so we help them support the Crown Act. They've had other supports around economic development or public safety to support that. So I'm most proud of that because it's external to our hospital system, and there's other folks partnering with us to do the work. And one thing I learned quickly was we can't do it all by ourselves. We have to have partners as well. So the question here is, do you have competencies of anti-racism for your frontline staff? The answer would be no, you don't. We are developing the right questions to ask around racism, around anti-racism, but I'm not one to develop competencies or a framework without first understanding what the root cause is. So, meaning for this, anti-racism is a buzzword, and it's a word that we should be doing in our communities and our businesses. But when you say you're doing anti-racism work, you're not addressing systemic racism or the root cause of it, you can't really get to the two framework of the competencies yet. So we're still in phase one of making sure we understand that. And then phase two will be seeing how biases and some other things impact that as well. That was a very good question, and I do encourage a lot of companies in the hospital systems to bite off and look at anti-racism work and make sure that you're digging deeper to figure out how we got here as well.
Is it okay if you should ask the questions, Adeli? Go ahead.
No, go ahead, Emily. I don't see any more questions. So if you have a question.
One just came in from Dr. Swenson, who is amazing, and she should get her question answered first.
All right. So Dr. Swenson asked, some institutions pay families to sit on family advisory councils and inform research and QI projects and reimbursement for their expertise seems essential to ensuring families from historically marginalized groups can participate. Do you have these at children, and do you reimburse families?
Yes and yes. So we do, we have a family advisory council, and the reimbursement process they use. We're creating also too for our collective improvement health and advisory council with the larger community, and we're paying them annual stipend for their work as well. Because you're right, Dr. Swenson, if you say to me that you've been marginalized for so long, but come in and provide you a free service to me and at no cost to you, we got to make sure we invest in the community. So we got to pay folks to do that, and also encourage folks to not only pay them to come to you, but also to go to them, invest in renting space from building, invest in going to restaurants in the community that people are from as well. So that'll kill, we don't kill birds here. That'll take care of two tasks to say, you know what, we're going to invest in the community and we're going to invest in coming to you while you're always coming to us as well. But short answer is yes, yes, and yes.
Molly, I think we have time for one more question if you have anything else you wanted to ask.
You won't have time to do the full version of the answer, but yeah, I just wondered about standard metrics that you might be looking at that we could look at our hospital as well, and particularly thinking about employee engagement surveys and some of that workforce diversity you were talking about. Are there items from the standard employee engagement surveys that you're tracking, or how are you looking at that?
We created our own questions around equity inclusion in the survey. So we track that, and after this meeting, we feel free to share with you some of those questions, but then rank those questions around equity and inclusion, and then we know what we can focus on going forward. And then we do have standard metrics in our strategic plan that identify the numbers as far as the lagging metrics as far as number hired, number retained, those kind of things.
All right. Thank you so much, James. I just really appreciate this. Over the last few years, and particularly I would say 3 years ago, we were all kind of scratching our heads. Like there was this increased awareness of health equity and how we needed to be more proactive, right? And I think you really demonstrated for us today some tangible things that we can begin to do around leadership development and metrics, having metrics that we're looking at every year. I hope that we can partner with not only you, but Hennepin as well, all the providers that care for children in the Twin Cities. So I really appreciate it. And I think you've also demonstrated just that we need everybody to be engaged in this work in some way.
Thank you very much, Anthony, for inviting me. I appreciate it. Yes, we do have to partner with Hennepin, Children's Sonic, Fairview, Health Partners, everyone. It's about the kids. It's about the families. It's not about competition in this area. The other thing I'll say is too, I do have a fee request. My fee request is I'm going to come back the same time next year. In a positive way by the University of Minnesota Pediatrics department around this work. So that's my fee request, and I want to make sure we get in part of the recording as well. So I'll be back this time next year to see how you do.
Excellent. Great. Thank you. Take good care, James.